Great, thank you so much. And George is always a hard act to follow, but good morning, everyone. I'm going to talk to you a little bit more about the California public health response now that George has set the stage nicely. And let's go ahead and go to the next slide. So I'm going to talk about this pandemic, this relentless, never-ending pandemic, in about 3 phases. So that early phase, I think we all remember, or it's hard to remember because it seems, especially in pandemic time, eons ago, but there was so much we were still learning early on, in those first cases. And I vividly remember that in the Bay Area, monitoring travelers from Wuhan. First, very, very early on, we weren't sure if it was person to person. And we didn't learn until much later how large a proportion of people actually transmit while they're not even symptomatic. But so that was something we learned over time. We really thought, and with those first cases, but we weren't testing enough, of course, we had a lot of limitations. But with those first cases, I think I certainly thought at the local level, we could, identify these cases, isolate them, do the contact tracing, and have our, intensive public health work to do that intensive contact tracing and really try to, contain. But we quickly got overwhelmed, right? We saw that we didn't have enough testing and learned that there were so many people in our midst that had already been here spreading to others. So I think we really very quickly, even with, mitigation that we had to shift to once we realized the numbers were really kind of our doubling time was rapidly increasing, that mid-March sort of initial stay-at-home was realizing we were not going to be able to contain this with testing and tracing and isolation and quarantine. And we realized, I think many of us in local and state public health would say and have been saying we've been under-resourced just to do our basic kind of communicable disease control. There's over 80 reportable diseases, a lot of other infectious things that George showed on that transmission slide. We didn't necessarily even have enough resources and staffing to do the basics, and we quickly got overwhelmed. So, and a lot of our, it's great to hear about some of the, and can definitely relate to a lot of the discussion about national data integration and consistent data collection, in a large state like California with 61 health jurisdictions. We do have a statewide surveillance system, but there are still a couple of jurisdictions that use their own. And then one of our big gaps actually was having a contact investigation sort of database parallel to that. So CalConnect was quickly set up in May of 2020. And then, of course, we know there was a lot of confusion as we were learning about, how is this disease transmitted, how quickly, how is the incubation period, how long are people infectious, and that really led to, again, a lot of changing recommendations. I think the public certainly could not keep up. We could barely keep up ourselves. And so I think also what unfortunately evolved, as we all know, is a lot of sort of decreasing trust in public health. And I think as far as, even over this first course of this first phase, I think people not even picking the phone up as frequently as our public health investigators were trying to. We quickly staffed up, but then also getting people to respond and cooperate with contact investigation was a challenge. Let's go to the next phase. And then we at least got through that first sort of summer surge, and we had a nadir. But then, and we developed the blueprint for a safer economy, which actually was in that last phase, but we issued that in early September. And then we started seeing increases again as we were gradually reopening. We again could not keep up with this virus that continues to outsmart us. So we did the regional stay-at-home, but we also at the same time are really thinking about how else can we have more effective and faster ways to notify contacts of cases. So it was really in the middle of that surge, we did manage to partner with all the great partners on this symposium to launch CalNotify in early December. And it was just in time for this humongous surge that you see here. And again, this really overwhelmed the public health system as far as being able to call and notify contacts. We also had a big diversion in need as we were very excited about vaccines coming, that our public health staff really needed to pivot and work on vaccine rollout too. So that also hampered our ability for kind of traditional contact tracing. So really helpful to have this tool. And then as vaccines started to roll out and as this next surge evolved, we were seeing that significant drop in cases and just loss of, the public started losing interest in, again, engaging in COVID. And, we're all tired of COVID and the public is really tired. Pandemic fatigue is really quite significant. So again, fewer people answering the phone. But we did note actually that during that spring of 2021, almost 3 times as many close contacts were identified with CalNotify compared to traditional contact tracing. So we were down to, only about 1.5 close contacts identified with our traditional contact tracing, and we had a much higher hits as far as our CalNotify. So we already saw then that we were having more effectiveness with this tool. And then we continue to see declines. Vaccination rolled out. We continued our coverage, and we reopened in June, mid-June. And then next slide. And here we are. We have been reopened since June, and George already nicely highlighted our new variant that started in around July and caused this most recent surge. And the other way I would sort of qualify this variant is it's like faster, stronger, fitter, and it just really, again, quickly overwhelmed systems. And again, the public is even more fatigued than before, and people are out and about and interacting. So next slide. So this is sort of where we are now. Thankfully, well, as George said, we were on the other side of the Delta surge, but we had been decreasing and now we've really plateaued, and definitely some concerns about increases. We were just talking this morning about hospital census in California and regionally, and we are already above our baseline census now, and starting to see some increases again. So we really do need innovative tools like this to enhance the speed and capacity of our response. We've already highlighted again the faster, stronger, fitter. I think the shorter incubation period is definitely a challenge as far as traditional contact tracing and just the timeline of notification. Again, more mixing in our economy. People have really started to return back to normal. And again, that varies hugely by region, as George was mentioning as well. And we've really had to, as this pandemic has gone on, not only have a lot of the state redirected staff that we had deployed to the local health departments had to go back to their regular jobs at the local level as well. All of our other public health issues are not going away. We thought we could put them on hold for a few weeks or months, but now people need to get back to STD investigations, tuberculosis, lead, all of the other important public health work that had been neglected for so many months. People are needing to go back to that. So we have actually, in a way, we have a lot of trying to hire, but as you've all heard in all fields, including public health, we cannot hire as many people as we really need to do the work well. So I think that's happening at all levels. And the other huge change is changes in our testing options, which is actually great. We have more and more over the counter and rapid tests available. We have more confidence in the rapid tests, which is great. But those are not all getting reported to public health. So we really want people to, we want them to impact behavioral change. And so that's what we need tools like CalNotify to do. And actually one exciting tool around this is we're preparing to launch a self-attestation option for CalNotify, so that if people are using home testing, they can, then upload that they've tested positive and then notify people. So it doesn't have to happen through our formal current process. And other data, just to note in this most recent phase, excuse me, during Delta, CalNotify is notified about 5 times as many close contacts compared to our traditional contact tracing, again, with public fatigue, I think, in answering the phone or text. Next slide. Excuse me. So some of our ongoing and new challenges. So we've already talked about the challenge, unlike a lot of those other diseases, is a much higher proportion of asymptomatic transmission, which is hugely challenging. It's very, excuse me, very clear now that this is an airborne transmissible disease. I mean, there's some droplet, but clearly a lot of airborne transmission, which just makes it so much more challenging. It's not just proximity, but really shared airspace. So we're really trying to modify a lot of recommendations related to that. Again, the scale of response that was needed for this pandemic was just above and beyond the last one we all dealt with in 2009. And it just continues to really challenge us. And it's, again, finds our susceptible and our most vulnerable. But we are continuing to discover effective interventions. It's great. We have new oral antivirals coming down the pipeline. We're continuing to see other treatments. But, not only has this, the science around this disease really evolved over time, which I know causes confusion, but obviously the polarization and politicization of what are effective public health interventions has really caused huge challenges in engendering public trust. And of course, as mentioned already by George, we are worried about new variants that could evolve and what that could do to changes in how this pandemic evolves. And a lot of the concerns and knowns about how long immunity lasts from prior infection and the huge variability around that, and even from vaccines. So I think CalNotify can really help us with a lot of these challenges. So it is efficient. There's little operational cost, a lot fewer resources as far as human resources, which is what contact tracing really needs. There's really almost an unlimited scale potential, which is really exciting. And obviously, it'd be great to think about how to leverage this technology for other diseases. So I think, looking again at chickenpox and measles and thinking about in our measles outbreaks, trying to do these public notifications about who was on a BART car or on BART between X time and X time and not knowing which car they were in. There are a lot of other applicabilities that we could use this technology for. And on that note, just being able to adjust that epi risk model, we've already adjusted it for Delta as far as the changes in parameters there and incubation period, and we could adapt this technology to do that as well. Next slide. So, of course, there are limitations. Not everyone has a smartphone. We absolutely know that. And there's a lot of equity issues around that. And there's, again, a lot of cultural and geographic differences in adoption of all kinds of public health measures, including this. And a lot of people who are adopting are likely already the more sort of public health conservative and, wearing their masks and avoiding crowds. And there's less likely adoption by those who have government mistrust. And I know there's going to be another panel talking more about this, but I think, just like our layers of mitigation, I think there's layers of tools and interventions, and this can help us with some of these large potential super spreader events where people don't know each other and can help do, help really supplement, and so that, where we really need to lean in with the human touch and trusted messengers is where we can use our priority public health staff and resources if we can use this kind of technology for these other mass settings. And again, it may work better for those who prefer to be anonymous. And then some people who might be willing to do this, even though they're not willing to get vaccinated or pick up the phone and talk to a public health staff. And again, could be a safety net tool by those participating in large indoor events or when traveling. So on that note, the next slide. So there are a lot of other efforts underway, and you'll hear a little bit more about this probably throughout the symposium, but to promote CalNotify to various audiences and venues where we want to increase adoption and use, and where we can have a lot of benefits. So already there's some efforts at testing sites so that people know, when they get the results to sign up, so that if they do have a positive, they could notify. Concert events and performance venues, we're working with a lot of organizations related to this and sporting events. So it'll be nicely paired with things like vaccine verification and sign up for CalNotify. Universities are obviously a great place and where a lot of this was piloted. I know you'll hear more about that too, and where we have had large outbreaks. We have young, very mobile people who interact with a lot of different people. So I think this is a great tool for that setting. Travel hubs and theme parks, just all of these places where we could really use the strengths of this tool to relieve pressure on other parts of the response and other parts of the public health system. So I will stop there. Thank you.